You know, your heart beats about 100,000 times a day. It's this steady, reliable rhythm that most of the time you don't even notice. But what happens when that rhythm goes haywire? When that steady drumbeat turns into a chaotic electrical storm? Well, today, we're going to untangle one of the most common reasons for that chaos: atrial fibrillation. So, have you ever felt this? That sudden exhaustion, a little dizziness, or maybe you've checked your pulse and it just feels off? If you have, or you know someone who has, you're not alone. These aren't just vague feelings. They can be the very first signs that your heart's incredibly complex electrical system is a little out of sync. All right, let's make this real. Picture this: a 70-year-old professor. He's doing all the right things, managing his blood pressure, but for the last couple of weeks, he's just been wiped out. So he checks his pulse and, whoa, it's not just fast, it's all over the place, jumping between 120 and 140 beats a minute. His heart is basically racing, but it's not really getting anywhere. And sure enough, an ECG confirms it. The diagnosis is atrial fibrillation, AFib for short. And you know, this isn't some super rare disease. It is the most common sustained heart rhythm problem out there. So now our professor is facing the same big decision that millions of people have had to face. What do we do about it? And that one question brings us right to the heart of the matter, the central dilemma in treating AFib. It's a debate that's been going on in cardiology for decades. Do you focus on the rate, or do you focus on the rhythm? So, you've got two main schools of thought here. On one hand, there's rate control. This is where you basically say, okay, the rhythm is chaotic, we'll let it be, but we're going to slow the whole thing down to a more manageable speed. Then there's rhythm control. This is the one that feels more intuitive, right? Let's just fix it. Let's get the heart back to its normal, steady beat. It seems like an obvious choice, but as you're about to see, it is way more complicated than that. To even attempt rhythm control, doctors need a pretty specialized set of tools. So let's go ahead and open up that antiarrhythmic toolbox and see what we're working with. First, just a quick refresher. An arrhythmia is, simply put, any disturbance in the heart's normal electrical beat. Honestly, the best way to think about it is like a software glitch in the program that runs your heart's hardware. Now, the mechanism behind a lot of these glitches is actually pretty wild. It's often caused by something called reentry. Just imagine an electrical signal getting stuck in a short circuit, just going around and around and around in this tiny loop, firing off signals and causing total chaos. The drugs we're about to look at are designed to break that very loop. And this table here breaks down the main tools into 4 classes, using a great racetrack analogy. Class 1 drugs, and by the way, it's pronounced Class 1, not Class I, they block sodium channels, which is like making the racetrack stickier to slow that signal down. Class 2 drugs, those are your beta blockers. They act like a pace car, setting a slower overall speed. Class 3 drugs make each lap the signal takes longer to finish. And finally, Class 4 drugs are like a gatekeeper at a really important turn, limiting how many signals can even get through. So these are obviously powerful drugs, right? They're designed to manipulate the very electricity that keeps us alive. But what happens when that power goes wrong? Well, that brings us to a really important cautionary tale in the history of modern medicine. This danger actually has a name: proarrhythmia. And it's a chilling paradox. It's when the very drug you're taking to stop an arrhythmia ends up causing a new one. And sometimes it's one that's even more dangerous than what you started with. The true scale of this danger became terrifyingly clear back in the late 1980s. A huge set of clinical trials, called the CAST trials, got underway. The goal was fantastic, totally noble. Doctors knew that after a heart attack, patients often have these extra irregular heartbeats. So the theory was, hey, if we use these powerful new drugs to get rid of those beats, we could prevent bigger problems down the line and save lives. It made perfect sense. But the results were an absolute catastrophe. Instead of saving lives, the Class 1C drugs led to a 3.6 times increase in death from arrhythmia compared to a placebo, a simple sugar pill. The very treatment that was supposed to prevent electrical chaos was actually causing it. They had to stop the trial early. It was a disaster. So you can imagine the fallout from this was profound. The CAST trials completely rewrote the rulebook. It led directly to the clinical guidelines you see here, which basically say that this whole class of drugs shouldn't be used for that purpose. It was just this humbling, powerful lesson in the law of unintended consequences. Okay, so with that really sobering lesson about the risks of rhythm control drugs fresh in our minds, let's circle back to our original dilemma. After everything we've just seen, you might be thinking, okay, rate control has to be the safer bet, right? I mean, just manage the speed and don't mess with those risky drugs. It seems logical, but what does the actual data say? Well, when researchers put the two strategies head-to-head in huge clinical trials, they got another massive surprise. Just look at this chart. When you compare the death rates for patients getting rate control versus rhythm control, they're basically identical. From the standpoint of what matters most, survival, it made no difference which strategy was used. And here's the really surprising truth that came out of all that research. The common sense idea that a normal rhythm must be better was just wrong. For a whole lot of patients, it turns out the risks of the powerful drugs you need for rhythm control essentially canceled out any of the benefits you might get from being back in a normal rhythm. But of course, the story doesn't end there. Medicine keeps moving forward. The focus today is shifting away from just lifelong drug therapy and toward more targeted interventions, like catheter ablation. This is a procedure where doctors can thread a catheter up to the heart, find the exact little spot of tissue that's causing the short circuit, and, well, zap it. For the right patient, it can be a much better and sometimes permanent solution. So today, the approach is so much more nuanced and personalized. It all starts with getting the diagnosis right. Then it's about having a really careful conversation about rate versus rhythm, weighing all those pros and cons. It means considering non-drug options like ablation. And it all boils down to this final critical principle. The goal isn't just to make an ECG strip look pretty. The goal is to give the patient a better and, most importantly, a safer life. And that really leaves us with this final thought, doesn't it? The entire story of AFib treatment is this powerful reminder of a fundamental challenge in all of medicine. In our quest to tame these electrical storms inside the body, the biggest challenge is often knowing when to step in and when our fix might actually be more dangerous than the storm itself.